Dr. Pratima, thank you for that introduction. And Dr. Prabhat, thank you for inviting me to be here. A busy outpatient, in fact, there's a busy outpatient waiting for me, interferes with my passion for tobacco cessation. I'm a physician, I'm also a pulmonologist. In both areas, I see huge problems caused by tobacco. And I know that any treatment I can offer is not going to be effective unless I get patients to quit their tobacco use. In advance, I'll say I'm going to use the term smoking, but it generally means tobacco use in any form. And I'm going to use the term he, but it refers to he and she, anybody who uses tobacco in any form. So what do I do when I come across a patient with tobacco use, or in fact any patient? I follow the 5 A's approach, which is generally advised. That's ask, assess, advise, assist, and arrange. So what do I ask them? The first thing I ask them, and this has to be fairly systematic and brief, is do you use tobacco? Do you smoke? Unfortunately, on an individual basis, this is not reliable, and this is something we've come across repeatedly. My residents who clerk in patients who come into the casualty very often don't even ask this important question. So one of the ways to do this is to make this a vital sign. They do record the blood pressure, they do record the pulse rate, and like that, along with the temperature and the respiratory rate, if we can make tobacco use a vital sign, it becomes extremely useful and will be done more regularly. The second thing that we have suggested the use of in our hospital is the use of tobacco use stickers. So every single patient's file will carry this question, do you use tobacco? And if they are, the sticker goes on. And then further action can be taken. So if a patient says he's a non-smoker, I usually also ask, so when did you quit? Because I find very often that my resident is willing to accept this statement, I am a non-smoker, and then they stop asking questions. If you ask the supplementary question, so when did you quit? He often says, I stopped a week ago or a month ago. In his mind, he's a non-smoker now, but it ignores his past use for many years of tobacco. So that's an important question. I'm a non-smoker. When did you quit? And he's willing to expand on that because he doesn't mean to lie. It's just that in his mind, he's not a tobacco user anymore. If he is a tobacco user, then there are many other questions to ask. Do you smoke or do you use smokeless tobacco? When did you start smoking or chewing? How long have you been smoking? The number of cigarettes or BDs per day? Did he make any previous quit attempts and how many? How long did his longest successful quit attempt last? I asked him, what made you quit the last time? Was it some health issue or were you inspired to quit smoking by someone else? And what made you start smoking again? Because this is important when you're trying to get them to quit smoking. Having asked them about tobacco use, the next is to advise them. And I advise quitting tobacco to every tobacco user. And this advice is made in a very clear, very strong, and personalized manner. What exactly do I mean by clear, strong, and personalized? When I say clear, I tell them, I think it is important for you to quit smoking now, and tell them that I can help you. It's not just aimless advice. It's saying, I'm here for you and I can help you quit if you're interested in quitting. Second important statement, for example, could be cutting down when you're ill is not enough, because that's something a lot of patients tell me. Oh, doctor, I used to smoke 2 packets earlier, but now it's down to about 3 cigarettes a day. And then, of course, when they're well, they start smoking more again. So that's the point to be made then. Cutting down when you're ill is not enough. The advice needs to be strong. As your clinician, as your physician, as your pulmonologist, I need you to know that quitting smoking is the most important thing you can do to protect your health now and in the future. So that's strong advice. It is the most important thing. But all this is useless unless it's personalized, which means that you have to relate the person's tobacco use to his or her current health or illness. You'll have to work out the social and economic costs, and importantly, tell them what impact it has on children and others in the household. So I tell them, for example, your breathlessness and cough are due to the damage caused to your lungs by your smoking. And importantly, tell them this damage is irreversible. A lot of people think, I quit 2 months ago and I'm still not better. So it's important to tell them that some of the damage is irreversible. So the earlier they quit, the better. A very useful thing that I find, and which has been proven in the world literature, is to get them to calculate their lung age, or you calculate it for them after you've performed a lung function test. And it's quite a shock to somebody who's 45 when he calculates his lung age and discovers that his lungs are 90 years old rather than 45 years old as the rest of him is. And that's one of the things that's proven to have a huge impact on getting patients to quit tobacco use. Another very useful thing, because all parents truly care for their children, is to tell them that, for example, your child's asthma is getting worse because of your smoking, or your child has a higher risk of developing problems because of your smoking. And important to tell them that it's not just smoking around the children, though that's the worst, but even smoke clings to their clothes and can affect the child in the future. So important to tie in their smoking with their child's health now or in the future. I next assess their willingness to quit. And if a person is willing to quit in the next month or so, I assist them to quit. And there are two ways. I either provide the intensive intervention if I have a lot of time. There are some days when I'm freer. And on other days, I refer them to the tobacco cessation clinic for intensive intervention. Both approaches work well. With some patients, they prefer to work with me because I've been looking after them for a long time. But with others, we're quite happy to go to a professional who can do a more comprehensive job than I can do. So individually, I assess them and decide, are they going to need my help alone, or will they get better care by going to the tobacco cessation clinic? And sometimes a combination of both works well. If they're not willing to quit, I try to get them to think about quitting, moving them from a stage of not even thinking about it to at least starting to think about it. And actually for this, I think the physician is the best person because they can quit, they can make the patient quit better by personalized advice. At this point, I also assess the level of addiction of the person, make them realize what keeps him smoking, or I realize what makes them keep smoking and what made them fail in their previous quit attempts, and work out the direct costs of smoking. Of course, the input is mainly by the patient. It's self-reported, but by and large, patients, I think, are honest, unlike what Dr. House thinks of as every patient lies. Of course, the Fagerstrom questionnaire, which I'm sure you all know about, the test for nicotine dependence, is useful, and I assess whether they're at low addiction potential or high addiction potential, recognizing that nobody has no addiction potential once they use tobacco. Of course, I identify what helped in previous quit attempts and what factors contributed to the relapse. And if a person is highly addicted, I often use a nicotine replacement therapy. If less addicted, but it's a situational issue. You know, there are certain times I smoke and other times I don't smoke. It's often in times of stress. I have a shouting from my boss and I come back and then I have to smoke. Then you suggest alternative methods, avoidance, alternatives like chewing non-nicotine gums. It's often a stress situation. Cricketers often keep chewing on gum on the field because it helps them with stress. And it's not necessarily the nicotine, but the act of chewing that helps them. Having made the assessment, I assist them to quit smoking or refer them to the tobacco cessation clinic. What I do is I give them some self-help tips. I give them a brief opportunistic intervention. That's all I can do in my busy clinic. And when needed, I use a pharmacological intervention. If the person has been a previous attempting to quit but failed to quit, I may refer them straight away to our tobacco cessation clinic because they will be able to give more intensive interventions, individual or group counseling, give them behavioral approaches, which I cannot do. I always keep in mind this particular study, which showed that the longer you spend with each patient, the more successful you are at getting them to quit. The more the number of sessions, the more successful they are in quitting. And with the total contact time is increased, they quit very well. So I try and emphasize the importance of quitting at every session and do a longer session for those who've previously been attempting to quit but not succeeded. So I try to increase the total contact time. What specific advice do I give? I get them to set a quit date, usually a couple of weeks later. I get them to get cooperative people, helpful people to help them in the quit attempt. So they tell the person, they set a quit date with that person and request their understanding and support. The first weeks are often critical and you must anticipate challenges during that time. And the main challenge very often is the nicotine withdrawal symptom. Total abstinence, of course, is essential because most people say, I will cut down and think about quitting later. They never really succeed in quitting. Of course, it's important that they remove tobacco products from their environment, so they don't keep a tobacco pouch or a pack in their drawer, because they often light up without even realizing it. And prior to quitting, they should avoid smoking in places where they spend a lot of time. So I said, don't go to the place where you spend a lot of time. It could be the office canteen. Please make sure you don't go there when you're attempting to quit. Simple tips, of course. Nicotine helps colonic movement. So when they quit, they suddenly become very constipated. So they'll have to take a lot of fiber and drink plenty of water. One of the main reasons I've found that a lot of my patients hesitate to quit is they need that cigarette in the morning to help them to start their bowels moving. Of course, you need to anticipate weight gain. Weight gain is a genuine problem, and especially works as a great deterrent for women who want to quit smoking. And you need to work on them in advance, not wait until they put on weight. Of course, never buy a pack of cigarettes used to be something that we used to say earlier, but now, the new rules may suggest that they can only buy a pack of cigarettes and cigarettes will not be sold loose. So when that rule comes into effect, we probably will have to change that piece of advice. Of course, you never store cigarettes and lighter, because people have often lit up before even realizing that they have started smoking. And of course, when they feel the need to smoke, they take a 10-minute timeout and the craving to smoke may vanish. Specific challenges, a lot of people ask me if they can drink. I usually advise them not to drink, because alcohol can reduce their willpower to quit, and then the willpower takes over. So I suggest that they continue to abstain from alcohol. A very common situation the person finds himself in is he has a glass in one hand, and then he feels that he must have the cigarette in the other. And unless he has that, the joy of the drinking and smoking is gone. So you need to get them to avoid that situation. Of course, if there are other smokers in the household, it could be a problem if that person continues to smoke. But giving up smoking in partnership often aids in quitting, because when you want to smoke, your partner in smoking often says, no, we are not going to smoke. One of the most successful quitters I had was a person who gave up smoking when his wife became pregnant. They used to smoke together, and when she had to give up, he gave up too. Pharmacotherapy, of course, is an important part, and often is decided on me in combination with the patient, what he needs, and of course with the tobacco cessation team. And pharmacotherapy, of course, can double or triple the likelihood of successful cessation, but it needs to be combined with counseling, which is why I do it along with the tobacco cessation team. Everything improves quit rates, even time, the great healer, even when there is no action taken, as you can see from the bottom of that of those graphs. The dark blue lines suggest people who never had any action, yet they quit as time went on. But unfortunately, we can double quit rates if we intervene. So at all stages, I emphasize that patient education is critical, and I spend a lot of time with patients. I provide positive feedback at all stages, and I advise the patient to reward himself at each predetermined stage, because quitting is not easy. And unless we can give positive feedback to the patient, he's not going to feel encouraged to quit. So that is a very, very essential part of the cessation effort. Last of all, we arrange for follow-up. We provide ongoing support. They can ring me up anytime in the clinic. And apart from this, we need to monitor whether they're really sticking to their cessation effort, their quitting effort. But apart from direct questions, which I trust the patient will be honest with me, I leave the more detailed parts, carboxyhemoglobin, breathalyzer, the cotinine levels in urine. I leave that to our tobacco cessation team. So to reiterate the key messages, we ask, we advise people to quit, we assess their willingness to quit and what they need to quit, we assist them to quit, and finally we arrange for follow-up and further support. Of course, there are various roadblocks to quitting, and these, for a person who does not wish to quit, we again emphasize the relevance to the patient of quitting tobacco use, the risks of continuing to smoke and the rewards of quitting smoking. We advise them about, or we assess the roadblocks to quitting, and we keep repeating this advice, hoping that at the 5th, 6th, or even 10th time, the person will take the advice. Thank you very much for your patient hearing.
Okay, thank you very much, Dr. Murli. I think we'll first take questions from our listeners from everywhere. So let's open it up for any questions or contributions that anyone anywhere might have.
You can unmute yourself and go ahead or let us know to unmute. Just two suggestions has come. First is from Dr. Saurav Das. He is a psychiatrist at Calcutta. His point is that exhaled carbon monoxide level can be used as a probably follow-up measure. And Ashish, who is in Pune now, I think Aurangabad, his question is there any index to quantify tobacco exposure? And is there any other index other than the pack years or smoking index for carcinogen exposure? Basically asking two exposure, tobacco exposure and carcinogen exposure.
The carboxyhemoglobin, the carbon monoxide exposure is a very, very good point. As I said, I leave it to my tobacco cessation team because they have the instrument. It's far more useful with them. The question about, or the point about, what was the second point, Dr. Prabha?
Carcinogen index for
the index for exposure. We use the pack years or the cigarette years as the most useful index. The problem is it's highly variable. Some people inhale and hold their breath. Some people just puff away without needing to hold them to inhale deeply. So it really is not a very, very good index, but it's the only one we have. I'm not aware of any other index that will tell us the carcinogen exposure specifically. And we need to keep in mind that the risks of developing cancer is a combination of environmental exposure, the tobacco use, as well as a genetic predisposition. So I think, looking at a single measure may not be the complete answer. I don't know if the others have anything to add to that.
I think it's very well known that there are several other toxins and carcinogens in tobacco smoke, but there has been no specific application to individual patients as far as that is concerned. People have looked at tobacco products and estimated the amount of tar and the amount of carcinogens in them, but they don't seem to have a direct application in the clinical practice. Pack years and the quantity of cigarettes consumed, they might be the most approximate indicators of such exposure.
Keeping in mind that a BD pack is very different from a cigarette pack.
I think the AFMC Pune has a question. Can you unmute and ask doctors from AFMC Pune? Or I should read the questions? Okay, you can start. Question is, do urban hookah smokers also come with lung problems?
Yes, they do. Absolutely. It's a myth to think that the water filters out all the harmful elements. In fact, because you need to inhale more deeply, you need to inspire with greater force, you actually get a greater exposure to the harmful elements. And obviously, enough comes through to give you the kick, enough comes through to give you harm. I'm aware of at least one study done somewhere in the Middle East, I'm not sure where hookah smoking was associated, nargile smoking as they called it, was associated with greater harm, greater risk of both acute respiratory symptoms and risk of COPD in the future.
Let me ask you a question. I mean, as a pulmonologist, you probably have patients coming to who are fairly sick. And perhaps very sick patients may be motivated at that moment in time to actually quit. What happens in patients who are not so moribund? Do you find them as receptive to advice as people with established disease?
I think it's a largely individual thing. There are some people who at a fairly early stage are willing to listen to the risks and take the decision to quit. There are others. I've had patients who have had laryngeal carcinoma, have had a laryngectomy, are breathing through a tracheostomy, and smoking, holding the cigarette to their tracheostomy opening. So it's a very, very individual response, and I really don't know how to predict who's going to take the suggestions to quit tobacco use and who is not. By and large, you'd expect that people who have reached a more advanced stage are willing to quit tobacco use, but very often it is that when they try to smoke, their cough gets much worse as they're smoking, and that is one of the key factors in helping them to quit. But people at any stage can quit. People at very advanced stages may refuse to quit.
Yeah, and I think that really holds the important message that perhaps if you wait till people are too addicted, then it's much more of an effort. It's important to catch people early in health practice so that quitting is relatively easier. But I think the other point to underscore is that as a physician, patients are likely to respond to your advice to actually change your behavior in terms of smoke or tobacco use.
Absolutely. I think the feed to the tobacco cessation center should come from the clinician looking after the patient.
Okay, this is from Pune, Deputy Director, Pune, Maharashtra. Are there easy to use analyzers available and cheap as well, I think, in public health perspective?
I'm going to hand that question to the two of you.
Yeah, I think now, when we started the tobacco cessation clinics, I'll probably talk about that when I talk about how to set up a specialized tobacco cessation clinic. But yes, carbon monoxide analyzers are fairly inexpensive. The last I heard was about 20,000, around 20,000 rupees. And they can be very valuable because, for example, with a person, let's say with alcohol addiction, you can do liver function tests and tell the patient they have problems. For patients with pulmonary problems, you can do lung function tests. The CO monitor is something, a lung function test cannot be done at every center. The CO monitor is a good objective feedback of, of the fact that the person is inhaling a lot of, is retaining a lot of carbon monoxide. And that can be a positive indicator of change, especially as somebody suggested earlier. If you monitor it and show them that initially your CO was high, now your CO is better, you're probably, breathing in cleaner air. That could be a powerful motivating factor for change.
Okay, sir, how you estimate the long age? I mean, some of the people might want to know.
Yeah. One of the easy to use things to get people to quit smoking is the lung age. Basically, there's a formula. It varies from place to place because it depends on the person's predicted lung capacity. We actually use what's called the FEV1, the forced expiratory volume in the first second, divided by what is expected for the person, and through a simple formula, which is available on the net. In fact, there are apps on mobile phones, smartphones, which can help you calculate lung age. And in fact, many spirometers these days give you the option of calculating lung age automatically. So when you do a lung function test, the lung age can come automatically as part of the report. So in addition to telling people you are down to around 50% of what your lung function should be, you show them your lung age, and that's actually much more effective. Because this question of your lung function is down to 50% often doesn't mean much to the person, because at rest, until your lung function drops to around 33% of what it should be, it doesn't really show up as symptoms. So if you show them their lung age and say, look, your lung age is 95 years, that really hits home to them. Okay, so it's a calculator that's available on the internet, and you can download it onto your smartphone.
I understand there's also a German app where you can actually show people how they will look if they continue to smoke and if they stop smoking 20 years later. So that can be a very powerful motivator again for people to change.
Yeah, it takes your current photograph and ages you artificially to show you how you will look if you continue to smoke, and what if you didn't continue to smoke. So that's again very, very effective. In fact, one of the most effective posters I remember in the UK was showing two women of the same age, one looking at least 10 years older than the other, and it says, guess which is the smoker. So that was a very, very powerful message. One of the other things that I think people may not be aware of is spirometry is not necessarily expensive. Dr. Pratima mentioned that it's not available in every place. You can actually get a mini or a micro spirometer, which costs just about 5,000 rupees these days. In fact, there are cheaper versions available for 4,000. And I think it's very important because one of the things we find is most patients with COPD are not diagnosed, do not reach us until they advance to the stage of very severe COPD, which is 30% or less of lung function. At which point it's often fairly futile to get them to quit smoking, though it's important that they quit smoking, but they've already become extremely symptomatic. So a screening tool, which comprises of something called the IPAG questionnaire, which is a primary care tool associated with the microspirometer, which shows that their lung function has dropped, is a very, very effective tool in identifying COPD early and getting people motivated to quit their tobacco use.
Are there any questions from the audience here? Anyone want to ask a question? Yes, please. Just introduce yourself and ask.
I'm Dr. Dinakaran. I'm a resident in psychiatry. Could you share with us, given that you see a lot of seriously ill patient, critical patient, could you share with us the success rate of your intervention? How people turn up after some intervention? Is there a good success rate? Because we get to see patients here who are young and with multiple other substances. We try to be treating them with other substances. Nicotine remains in the lag. So could you share with us about your results?
sir. There's a request for repeat the question. I think it's not audible because of the question is by Dinakaran. Dinakaran is a resident psychiatry at our institute. So its question to Dr. Murli is that in the setup like pulmonary setup, you see a lot of patients who are probably severely ill or hospitalized, and the chance of what is the chance of response to the advised treatment. And basically, in contrast, what case we see here are mostly are multiple drug addictions.
That's a good question. Unfortunately, I can't give you an accurate answer to that. I think the important thing is a lot of them do quit. So it's really rewarding to spend time with them trying to get them to quit. I can only tell you that maybe about 50% of our patients have quit by the time they reach us, people who've been smoking for many years, because they've realized that they should quit, that it's already time to quit. We probably help, of the remaining 50, we probably help another 10 to 20% to quit at their very first visit. And then a small number add on with each visit. And we increase this number. I'd estimate, again, this is a very rough estimate, we double the success when we tie up with the tobacco cessation clinic and get them to double their quit rates. So overall, I'd say we're fairly successful in between 75 and 80%. Unfortunately, this is, at least 50% have already quit after the damage has occurred. And while it's very useful, I mean, we always emphasize to them that bronchodilators work much less well when they continue to smoke and work much more effectively. So their symptoms are likely to improve if they quit smoking and take their medication. So I'd say we add on another 25% to that initial group who had already quit.
I think Dr. Dinakaran's raised a very important point, especially for psychiatrists who see patients with polysubstance use. There used to be a tendency to kind of not worry so much about tobacco and to handle all the other drugs. I think that has changed over the last 10 to 20 years. And we try and get people, encourage them to stop all substance use, because invariably maintaining one substance use is a risk factor for other substance use. And now that we have the support systems, both psychosocial and pharmacological, it has made getting people motivated to change their tobacco use patterns more easy and cessation more likely to happen. Dr. Pragati, yeah.
Dr. Murli, do you ever give up on a patient? Considering your busy practice and things, and you're investing a lot of time, if there is several times relapse or something, do you ever give up on a patient?
That's a very good question. I don't know if people heard it and they want to.
Yeah, I think this question people can respond to this question before I get sir to respond. A person who is been advised repeatedly to quit again and again, in spite of that, things are not going in place and he continue to smoke. How you all will respond to the situation?
Yeah, that's a very good question. And
somebody commented a question, awesome question.
Yeah, I don't think I ever give up. Now the question is, do I spend enough time? As I said, every time if a patient has significant damage, I take the trouble to talk to them. If I find that I'm not very effective, I get them to go to the tobacco cessation clinic, but I will ask them every time they come, have you quit? Have you quit? I don't ever really give up on them, though it's very tempting sometimes. Sometimes you get really frustrated. You can make out this person is damaging himself. He's quit, but then he's relapsed again. It is tempting, but actually every time that he says, I quit, last time I quit for 3 months, now I've relapsed, you feel encouraged. He did 3 months last time. Can I get him to extend it to 6 months? Because that is going to prevent further lung damage. So answer in short is no, I don't quit as far as possible.
If I can add, I think I agree to this point. In my practice, where I see, I try my best, even sometime to go to extent of using multiple pharmacotherapies, basically, to back. So often they don't quit. One reason is that obviously brain doesn't allow to leave it. The brain wants that thing. And giving analogy that if you're full in stomach, probably might not eat more. So using good amount of nicotine replacement therapy or varenicline, along with things, it works. So worst condition, he tells, can I have smoking and use gum? Nowadays people tell, yes, you can do it. It's not that, unlike the past, you have to stop everything, then you start a NRT. Nowadays it's not like that. You can still have reduce the thing, and probably he may not ready at this point of time, might be after 6 months ready, but I think policies are not going to go behind.
And another point is that a lot of patients who relapse don't feel good about relapsing. So they feel very shameful very often. They may not even talk to you and talk about your tobacco status, or even if you do, they won't, they won't discuss it. So I think the important thing that we do is actually educate patients about the likelihood of relapse and tell them to please keep in touch with us. And if it doesn't work, it's not a failure. You actually learn from the previous lapse to try different strategies, and we will help them with those strategies. And I think that's very important, because a lot of people need about 4 to 5 quit attempts sometimes, before they actually can successfully quit. So helping them along that is very important. And I'm sure you help people on along even after the damage is done, and hold their hands, till perhaps.
Yeah, the fact that they've quit smoking doesn't mean to say that lung damage stops. In fact, we nowadays think of COPD as an autoimmune disease. And so the damage continues even when they quit smoking. So we have to hold their hands through the rest of their problems. It's actually not the difficult part of it, helping them to quit smoking in terms of giving up. But yes, sometimes you do find it's very frustrating.
Okay. On that note, thank you very much, Dr. Murli, for being with us here today. We won't keep you from your patients. So I think.
Just to add on, those who got the last email has got a book attached to with that email. A book name is Helping People to Quit. The manual for physician and dentist. Dr. Murli is one of the author of the book. I will urge all of you to go through the book. It's one of the best pieces which I have read for last couple of years. Thank you, sir.
Thank you all.
Thank you very much. Okay, and now we move on. I'm going to invite Dr. Sujata. As I mentioned earlier, Dr. Sujata is Professor of Oral Medicine and Radiology in MS Ramaya Dental College. So now we're going to look at how a dentist can actually be a very, very important health professional to address tobacco cessation. Dr. Sujata, over to you.
Dr. Sujata, you have to unmute your mic.
Yeah, very good afternoon. We have started our year 2012. Is it audible?
Yeah,
yes, go ahead.
Am I audible?
Yes.
Hello. Yeah. So I'll just briefly tell you how we set up this dental clinic in our hospital, a tobacco cessation clinic. This was started way back in the year 2012, so it's almost 2.5 years old. And so far we have treated around 522 patients have registered here for tobacco cessation.
1 minute. Dr. Sujata, can you make the full screen of this PowerPoint?
Yeah, sure. So we have been seeing a lot of patients on a regular basis. It's only a few of them who are really willing to register for this tobacco cessation services, for the counseling, and are really willing to quit the habit. So the quit rate here has been around 9.1%. Okay. And we started our clinic in a very small place in a part of our department of oral medicine and radiology. The clinic measures around about 10 by 10 feet, and the different facilities that are available in our clinic is we just have a carbon monoxide monitor. Okay, so the patients who regularly register with us we take down a detailed history of the tobacco habit, assess their levels of addiction, and they're regularly followed up. Okay, and we give them some educative materials, and follow-up is also being done on a regular basis. And as I said, the supporting staff here is my colleagues here, and we have a postgraduate students who help us in this tobacco cessation services that we provide to our patients. And we also have certain training programs going on from our tobacco cessation clinic here. We have trained more than 300 dental health professionals from the Rajiv Gandhi University of Health Sciences. So we have all trained them in a 2-day hands-on workshop along with NIMANS faculty, and they've all been trained in tobacco cessation services. And apart from that, we have also done training of school teachers in tobacco cessation services, and also we have covered more than 3,000 and odd children. More than 35 schools have been covered in and around Bangalore city, where we have educated children about the ill effects of tobacco, and also we have done a screening. And the statistics are quite alarming. We found around 11.2% of the school children, high school children, have been using tobacco. Okay, and a few pre-university and university colleges also have been covered in this tobacco cessation programs. So this is again, we have Dr. Katima Murthy, madam, and the team from NIMANS. Here we have a tobacco cessation services training, which is provided to health professionals here. This is the photograph celebrating that. Next one. This is again our school children tobacco cessation program, where we have covered more than 3,000 and odd children here. Next one. This is again a tobacco cessation training program for school teachers. More than 350 teachers have been trained in this so that they could go back to the respective schools, and they were asked to set up a health corner or a tobacco cessation clinic in the respective schools, and also to provide a one-to-one counseling for the students or children who approach them with this habit. These are some of the training programs that have happened in our college, okay, in our tobacco cessation clinic. Would you like me to encounter this tobacco lesions also?
Sure. In the next 5-10 minutes, you can show us these.
Yeah, I've been a dentist. We have certain lesions that occur in the oral cavity because of chronic tobacco use, and these are some of the risk factors. So tobacco can be a risk factor for the onset as well as exacerbation of certain painful oral diseases. That includes from simple dental caries to gingivitis or periodontal diseases, gum diseases to ulcerations to serious ones like the pre-malignant and the malignant lesions. So the other findings that we have found in the chronic tobacco users have been the salivary flow, the reduced salivary flow, both quantitatively as well as qualitatively reduced salivary flow has been found, and we have also noticed impaired wound healing, especially following tooth extractions or following minor oral surgeries, where the healing period has been extended, and there has been exposure of the root surfaces because of, especially in chewing tobacco users, where there is a placement of the quid against the teeth. So where the roots have been exposed to the oral cavity, and patients have complained of pain or sensitivity, and the mucosal drying effects because of the reduced salivation, and especially because of the smoking tobacco, we have found increased intraoral temperature and also the changes in the pH and certain local alterations in the immune barriers of the oral cavity. So I've just divided this as to what happens to the soft tissues of the oral cavity as well as the hard tissues, as the teeth of the present in the oral cavity. Coming to the soft tissue lesions, the ulcerations are very common. As I said, gingivitis, the gum problems are very common. Other than that, we have certain pre-malignant lesions. That is the ones which have they have a tendency to go for a malignancy. Those lesions include leukoplakia, erythroplakia, oral submucous fibrosis, and the frank oral cancers. So just put a few pictures. This is again, the first one is a picture of a hairy tongue. In chronic smokers, we see elongated piliform papillae and discolored tongue. And the second one is the median rhomboid glossitis. It's again a very, it's like a form of candidiasis. It's very common among chronic tobacco users. This is again an atrophic type or erythematous type of a candidiasis, which is very common among smokers. And this is the leukoedema. This is the very first sign of in chronic smokers, where the mucosa, which is usually red in color, pale pink in color, becomes very pale and whitish in color. So on stretching, it gets back its coral pink in color. This is one of the lesions, which early lesions that is seen in chronic smokers. This is leukoplakic lesions. It's a white, non-stapable lesions, which is commonly seen in both smokers as well as chewers. Okay, and this type of a lesion, the second one, the leukoplakia is this kind of a leukoplakic lesion, and along the corners of the mouth is seen, especially in the BD users, because they tend to place their BD more towards the periphery of the mouth. And this is again a leukoplakic lesion on the tongue, and the last picture shows leukoplakic lesion on the palate. This is especially seen among chronic reverse smokers. This is especially practiced among fishermen and women along the coastal areas. This is again erythroplakia. It is a red and white lesion. It has got a very high, it is very prone for malignancy. Okay, and this can easily, within very short duration, can convert into a frank malignancy. So as erythroplakia, it's very common in the cavity among, especially both among smokers and chewers. In our experience, we have seen this leukoplakic lesions more among in the tobacco chewers. This kind of a lesion is known as the chewers mucositis. This is where you see the oral mucosa appears wrinkled in appearance, and it is discolored. It is commonly seen among chronic tobacco chewers. Okay, and this is what I was telling you. Oral submucous fibrosis is very commonly seen among chewing tobacco users, especially the commercially available tobacco, that is the pan parag gutkhas. We have seen this kind of lesions within very short period of usage. duration after say around 18 to 20 months of usage, we have seen this kind of a lesion. It's a pre-malignant condition. That means it's got a tendency to go for a malignancy. Here the mucosa appears very pale. The patient complains of inability to open the mouth completely, complains of burning sensation on taking hot and spicy food. And this is another lesion, oral lichen planus, though it is not directly related to tobacco use. It is more of an autoimmune disease, but this is very commonly seen among chronic tobacco users. And this is again a frank oral malignancies or cancers. This can be more of a proliferative type, where it extends out, or it could be an ulcerative, a burrowing kind of a lesion. And now next, what happens to the teeth because of chronic tobacco use? We have the dental caries or the tooth decay, wearing away of the tooth, that is the abrasion, erosion, and staining of the teeth and loss of teeth. Because of the chronic use of tobacco, which affects the gums and the attachment structures, the tooth become very mobile and then they tend to exfoliate by themselves. So this is how the caries process actually starts. We see the initial lesion where it appears white chalky in appearance, and as the lesion progresses, it tends to get discolored, and over a period of time, the tooth tends to fracture or it completely dissolves. And it's a very painful condition that could lead to abscess formation, swelling, okay, and other systemic manifestations as well. And the periodontium are the structures which support the tooth. That includes the gum, the supporting bone, and the other periodontal ligaments. So gum diseases are very common among tobacco users. This is the staining of the teeth, what we see. And the second picture shows the gingival decision. This is commonly seen in chewing tobacco users, where there is a quid placement. Because of the chronic mechanical irritation, the gingiva is lost in that area and the tooth tends to become mobile, and over a period of time it can shed on its own. This is again a picture which depicts the difference between a healthy periodontal tissue and healthy gingivitis, healthy gums, and the unhealthy one, where we see the gum extending up to the neck of the tooth, the supporting bone and the gums extending up to the neck of the tooth. And the second side, the one on your left-hand side, shows the deposition on the tooth, which leads to gingival inflammation, the gum inflammation, and the loss of bone, and which eventually leads to tooth fall on its own. And the other effects due to chronic tobacco use includes delayed wound healing, altered taste. Patients complain of altered taste. Sinusitis is very common among chronic smokers. Okay, and this is our clinic, Navajivana. It is in the Department of Oral Medicine and the Ramaya Dental College, and these are the services we have been offering in the last 2.5 years.
Thank you very much, Dr. Sujata. That was very, very illuminating. And I think it's a big lesson to all of us who are not dentists. And we see patients who use tobacco use to get patients to open their mouth and actually look into the mouth. Do we need any special, facilities to be able to do the oral examination? What would you suggest for all physicians, especially when you're assessing tobacco use? Do they need any special facilities to do an oral examination?
No, nothing much. It's a routine oral examination that we do. It's using a mouth mirror and probes. And as such, dentists, we get to see a lot of healthy patients. And patients of all age groups, right from children to the senior citizens. And as I said, tobacco has its own telltale signs in the oral cavity. Even when the patient is not willing to give up the tobacco habit, there are certain stains and ulcerations and certain diseases in the oral cavity that we can predict a tobacco user. So in our clinic, we just have a tobacco, we have this carbon monoxide monitor that is just to motivate the patients. As I said, and nothing much is required for this to set up this kind of a clinic.
Okay. The other thing coming from the last discussion is, for example, to take a picture of the oral cavity now with mobile phones and all that. How do your patients respond to it? If you showed them a picture of the lesion in their oral cavity, is that a good motivating factor for them to change?
Yeah, of course, it is a good motivating factor, and we also have our intraoral cameras in the department. So it is a routine practice. We do show them the oral lesions and we do motivate them and educate them regarding this. We can also use our mobile phones, take a picture, and we can educate the patient and motivate the patients regarding the ill effects of tobacco.
Prabhat, are there other questions?
Yeah, lots of questions, I think. The one question is from Pune. Is there a specific scale to assess this smoking or tobacco can be used by dentist?
The phlogiston scale, we have been using it regularly, and we also use this. We have this phlogiston scale for both smoking and chewing tobacco. We have been using that regularly to assess the level of addiction. Other than that, we are also using our carbon monoxide monitors. And as a part of a small research program, we also taken up the salivary protein level assessment in our department. So we've been doing that for a few patients. Routinely, we use the phlogiston scale for assessing the level of addiction in the patient.
I think I will agree with this response that phlogiston scale for both nicotine smoking, which only has 6 items, and smokeless, which is only 10 items, is one of the pretty decent scale to be used. I think for convenience of all the participant, I'll ask them to email a scale. It's openly downloadable, but you can ask both smoking scale as well as smokeless screening scale. We can use it for feature. Another question for Dr. Sujata is, what is the problem? Okay. Yes. So, Dr. Sujata, you have to. I'll read the question, then you can unmute and go ahead. What is the prognosis for blackening of mucosa in chronic smoker and tobacco users? This is from Dr. Saurabh Antara.
What is the
Prognosis for blackening of mucosa in
mucosal pigmentation is very common among chronic smokers, sir. And in our experience, we found once a person has stopped smoking to some extent, it has been reversed. And there are certain specific treatments that have been done for depigmentation of the mucosa has also been done here in the dental college.
Dr. Ashish, the question is that what are differences in the lesions due to smoking?
What are the differences in the lesions?
Yes, due to smoking.
And Dr. Ashok, can you clarify that question, please?
In smoking and non-smoking, what is the exact difference?
Okay, the lesions
So
between and non-smokers.
Yeah, the oral lesions which occur due to tobacco are the same, whether it's the smoking or the smokeless. We have found the same kind of lesions here. As I said, the pigmentation, the blackening of the mucosa is more common among smokers. And as I said, mentioned a certain pre-malignant lesions. We have found this oral submucous fibrosis is very common among the chewing tobacco users, especially the commercial tobacco users, because the areca nut coated with tobacco, the pan parag and the pan masalas, they found oral submucous fibrosis exclusively or commonly among chewing tobacco users rather than the smokers. And pigmentation of the mucosa we have found exclusively in smokers compared to that of chewers, tobacco chewers. Other than that, most of the lesions are the same, whether it's the smoking or the smokeless tobacco.
I think last question I'll take it up from Dr. Ashwin. Are there any evidence where nutrition prevents a chronic smoker from all lesions, especially leukoplakia? I mean, I don't think it's yeah.
Nutrition.
Yes, does nutrition protect from develops leukoplakia?
As such, I have not come across any such studies, but as a part of our treatment therapy, we do advise the patients to take a lot of vitamin E's and B complexes. Vitamin A and antioxidant therapy is a part of our treatment of any of the pre-malignant lesions. So it is said to bring down the malignant rate down by some extent, and also reversal of early lesions.
Okay. Right. I think thanks, Dr. Sujata. I will stop here. And
Okay. So we've so far discussed how tobacco cessation can be done in busy medical practices as well as in dental clinics. But then we also can undertake tobacco cessation very effectively in a dependence treatment facility. So I'm going to talk about how can you set up a specialized tobacco cessation clinic. Now this could be set up in any kind of health setting. We look at the necessary personnel and other facilities that you need. We'll just give us a moment to put the slides on. Okay, so I mean, we've heard through all the last few sessions how setting up tobacco cessation is a clinically effective and cost-effective method, because as many of our panelists were already discussing, it can actually be very cost-effective, and the cost-effectiveness of tobacco cessation compares with routine medical interventions. So whether it's early cancer screening, early breast screening, and prevention of morbidity and mortality, tobacco cessation is very similar, and such interventions can actually provide and prevent a huge number of medical risks. So I'll just give you a brief history of how tobacco cessation started. It was very gratifying to hear Dr. Sujata say that they started this TCC in 2012. So I'm going to kind of rewind to 10 years earlier. It was around 2002-2003 that the government of India, in conjunction with the WHO country office, set up on an experimental basis about 11 tobacco centers all over the country. And as you will see from this map, they were set up in psychiatric centers, in a dental college, in a community setting, in a cardiology center, in a respiratory institute. So they tried out the model in a diverse set of institutions way back in 2002-2003, and now it's kind of expanded to many other settings all over the country. And when the program started, the whole idea was to develop standardized manuals and systems that were to be used at all the TCCs. The 11 expanded to 18 centers at that time, and thousands of clients were treated. And through outreach and tobacco control programs, several lakhs of people were actually covered. And that experience resulted further into an expansion into the National Tobacco Control Program of the country. So manuals were created, for example, for the cancer control program. Self-help tips were developed on how to help people for tobacco cessation. And as Dr. Murli mentioned, it is some of these self-help tips that can be very, very useful in clinical practice to get people to quit. So what was this tobacco cessation model? We looked at offering simple tips to quit, behavioral counseling, pharmacotherapy, which consisted both of nicotine replacement therapy and non-nicotine replacement therapy, and intensive tobacco dependence treatment, where there is not only motivation to quit, but also teaching people how to deal with relapses. Now you must remember that at about 2002-2003, only nicotine gums were available, none of the other paraphernalia were available, and bupropion was available to a limited extent. So we had one NRT, which was nicotine gums, and we had one non-NRT, which was bupropion. But many of the centers at that time did not feel confident about using these pharmacotherapies. So the TCC experience of the first 5 years saw about 34,000 registrations across the country. About 23,000 patients, there was detailed information available. At follow-up, among the 23,000 registered clients, about 10,000 people maintained follow-up at 6 weeks. About 12,000 were lost to follow-up. Remember, this was the initial phase where follow-up did not form an important part of the program. One of the things it taught us is that it's necessary to follow up patients and find out what happens, because in a busy clinic, they can often drop out for various reasons. But at 6 weeks, when you looked at it, 31 of the 10,000 patients, 31% had quit completely, 49.5% had reduced intake by 50% or more, 8.7% showed no change. And even assuming that loss to follow-up had not improved, there was a 14% complete quit rates, 22% of reductions, and 50% or more had not stopped the smoking or the tobacco chewing. What you must remember is that this 14% and this 22% must be compared against natural quit rates. In the Global Adult Tobacco Survey, when patients were asked whether they had quit in the past, only 1%, 1 to 2% of smokers and chewers say they were past users and have currently quit. So in a public health model, if you can raise that to 14% quit rates and 22% significant reduction rates, it's a very, very important and valuable contribution. It is said that addiction outcomes are no different from outcomes of treatment of hypertension and diabetes. They're all chronic relapsing conditions, so one need not fear that patients are not changed. It is important to keep them in the loop and continually motivate them to change. Now, this is a very, very important graph, and I would say the most important graph. This is, if you keep in contact with patients, over time, more and more patients will convert from active users to reducers or to quitters. So this suggests that over 6 months, a lot of patients significantly converted from using status to non-use status. So if you persist with tobacco cessation counseling, you can make this kind of a change in all the patients. A lot has changed since then, and I believe that our biggest improvement is that our clinical expertise in how to counsel patients has improved. More specific medications have become available. Varenicline has been available now. Various other forms of NRT have become available. NRT has become more easily accessible in many parts of the country. And we've integrated tobacco cessation into other addiction services and indeed other medical services in different parts of the country. We've started using mobile telephone to help to follow up patients. And that's again very useful because patients then feel happy that somebody is remembering them, trying to help them, and that can also improve quit rates. And many other centers, Dr. Sujata is just one example of the many centers that have themselves set up tobacco cessation facilities. And then these tobacco cessation centers have also moved beyond just clinic cessation. They've moved to outreach programs in the community, like Dr. Sujata presented, schools, colleges, slum areas, workplaces, and a lot of training materials have developed for different health professionals, as well as training civil society organization in tobacco cessation. And there has been a lot of advocacy, as you know, through tobacco control legislation and through the setting up of tobacco programs at the state level, which my colleagues will talk about in future. There's a lot of IEC material, awareness and education materials that are now available in multiple languages. So nobody who wants to start a TCC now needs to develop these anew. They're all available. And if you have any difficulties in procuring them, please get in touch with us and we'll facilitate that you will get this material to put up in your clinics. So there's a lot on simple helps to quit, how to keep or how not to relapse, what you should know about tobacco use, what you should do about tobacco use, and so on that's available. Dr. Prabhat already alluded to manuals for medical officers as well as for nurses and other health professionals. So it's important to understand it's not only the medical officers who need to be responsible, not only the doctors, but other health professionals who can also be trained in providing tobacco cessation. The Government of India has come up with training modules for doctors under the National Tobacco Control Program. A TCC can be set up in any hospital, a medical college, district hospital, regional cancer center, TB center, medical and dental colleges, in a primary health center, in a public nursing home, in a private nursing home or in a public hospital. It can be set up by NGOs and it can be set up by private practitioners who can sometimes spare maybe half a day for a tobacco cessation clinic. The clinic should obviously be located in an accessible place in the hospital. It should be properly signaged. It should be visually appealing. You must be able to give the patient an idea that this will help you to quit. That's the most important thing. It's useful to have, of course, a medical officer because it involves pharmacotherapy very often, especially if people are severely addicted. A trained counselor, if you can find a psychologist, well and good. Otherwise, a trained counselor can be used. A social worker is useful. If you want to maintain the data, perhaps a data entry operator, but increasingly with doctors themselves maintaining their own databases, you probably don't need it. I'm talking about this staffing under the WHO program, but my suggestion is that just one medical person and a counselor is more than enough to start a tobacco cessation center. You need furniture, a table and chair to sit down in. You need a private space. A carbon monoxide analyzer is useful. An apparatus to measure blood pressure, a weighing machine to do a BMI analysis, a computer to maintain your records. some drinking water facility for the patients. TV would be lovely because you can pay the patient spots on tobacco cessation and the advantages of quitting, and other IEC materials are something that you can keep. You need to have, we have an intake software at NIMHANS where we can very easily measure the patient's background characteristics. We do the phagostrons routinely for both smoking as well as smokeless tobacco. We have the software which we'll be happy to share with others. NIMHANS has been acting as a resource center to places all over the country. And now tobacco cessation has become a vital component of the National Tobacco Control Program. And in that context, how it has expanded to the state and the district level, my colleagues will talk about. Finally, I just want to add that every health professional should be an advocate for tobacco cessation. So at the individual level, it is very important, just as Dr. Murli said, just as Dr. Sujata said, every one of us needs to do the 5 A's for tobacco assessment and advice. But a specialized tobacco cessation center is useful because we can then increase the quit rates by about 7 to 8 fold. And that is the advantage of having these specialized centers. I'm happy to take any questions about this. Otherwise, we can move on to the next discussion.
I think Dr. Praveen Sultana, can you, I mean, you have a couple of questions. Can you unmute and go ahead? It will be nice. All can hear. Let me check.
Dr. Parveen, can you unmute your mic and come on, please?
I have unmuted your mic.
Go ahead, Dr. Parveen, ask your question.
Hear me, ma'am. Good afternoon.
Yes.
Yeah, I worked in a university hospital, and being a psychiatrist, we were like posted in a rotation. Like we have to go and counsel the students who come into these counseling for student counseling. You know, they just come in to have some suggestions regarding like they're feeling difficulty in studies, and most of them are from North India, and we are based in South India. The cultural differences, and most of them have this smoking, and they're almost up to the addiction. We do this vegan storm and say yes, you are addicted to it, and you have to start the NRT. And some of them do agree. They said, okay, we will come back to you for the NRT, and some even like start and they come for follow up for 1 or 2 follow ups, and then they do not turn up at all. And we do not hold any personal information from these students, like their personal contact numbers, because the students don't feel comfortable to give their personal information. And sometimes if they score very low marks, they think that that can come up against the university may take some action. So we do not hold any personal information. So how do I tackle this issue with this follow-up with these students? Mainly the college students in the first year and second year.
That's a very, very interesting situation that you're in, and a lot of challenges that you face. So clearly the approach in a university setting is quite different from what we do in a tobacco cessation clinic. Your messages for a start need to be quite different and need to appeal to younger people. You need to look at the earlier, consequences of tobacco use rather than the late consequences. The third thing is, as you very rightly mentioned, a lot of people seem to use tobacco to handle stress, to handle other psychological problems. So I think perhaps also addressing some of these issues will make tobacco cessation more meaningful for these students, because in the absence of that, just telling them to stop tobacco may not be a very good idea. And involving peer counselors is a very, very good approach in university settings, because very often peer counseling is much better accepted. So perhaps one of the things to do is to train interested people in counseling amongst the peers to also try and develop the skills. The other thing is now using mobile telephony, assuring confidentiality, especially if students are frightened about the consequences, assuring these things. These are some of the colleges that we've spoken to. These are the strategies which have helped them to really help people to kind of change. Of course, if they're addicted, to encourage them to go and seek tobacco cessation in a specialized center. These are some of the tips that I could suggest.
Thank you, ma'am.
I think Dr. Bhubaneswaran has also similar comments toward Dr. Sultan's question. Sometimes follow-up depends on the reason of our first visit, who referred, why they came, and probably motivation enhancement counseling should be tried. I think the bottom line is that having good repo and probably not being too much pharmacotherapy at the first visit with lot of messages might help.
I think you just hit the nail on the head. I think building a rapport and trying to convey to people in a short, in a few minutes that you're very concerned about them and are willing to help them is probably the secret to helping people change. And that's where I think some of the discussions we had earlier, what Dr. Murli said, that some patients prefer to see him because he is their doctor. And then it becomes very easy to then integrate tobacco cessation rather than if you simply refer them on to somebody else without preparing them, you can lose your patient. So I think that's a very, very important message, that you make the person, convinced that you're concerned about them, and then the rest of the strategies automatically fall into place. But for young people, mobile technology internet and other technologies are very, very useful methods. In fact, the WHO with the International Telecommunication Union is looking at the use of mobile telephony in India because telephone penetration is so high, whether you can send messages, whether you can use internet-based modalities as a mode of intervention. In the interest of time, I'm going to cut this discussion and move on. We can take more questions at the end if we have time. Let me now invite Dr. Pragati Hebbar, the Advocacy Officer of the Institute of Public Health, to talk about some of the things that they are doing outside the clinic. I think tobacco control cannot be effective with only tobacco cessation in a clinic-based format. We need to move outside. We need to see what's happening in the country. And this becomes particularly important when we're having debates at very, very high places about whether tobacco really causes cancer, whether tobacco at all should be, promoted or prevented. These strategies become very, very important when we are faced with such situations. Dr. Pragati.
Thank you, ma'am. A very good afternoon to one and all. I hope you can all hear me clearly. So just a few seconds, they're setting up the presentation. Yeah. So in the meantime, I would just like to start any which way. So I'd like to start from where the stage I think has been set very aptly by the other speakers. So starting with how do you set up a cessation clinic, be it in a private practice, be it in a dental college, be it in medical facilities. So now what is your role as an individual? So going out of your clinic, we'd also like to see that what are the various strategies, what are the various tools you can use to move policies into practice. So many a times, as you know, even the COTPA law as such, the Cigarette and Other Tobacco Products Act, which was enacted in 2003. So it's more than a decade now, but still the implementation is quite lacking. So what are some of the things as a health advocate that you can contribute in this field is something that I'd like to discuss. So, starting with advocacy, just what is advocacy? Basically, it's just to write or speak of something that you would want to support. And if you go with a more comprehensive definition, it would be a combination of all the social actions that are designed to gain political commitment and a policy support, social acceptance and system supports for any health program. So, even if you are from a health background or a non-health background, what exactly can you contribute in this? So as a term, advocacy is quite broad and it captures several aspects. So some of these include research. So good advocacy is always supported by sound evidence, scientific evidence. It also involves a lot of planning and coordination among different people. Another key strategy is alliance building. So you need to have like-minded people or organization, which is always helpful. And some of the components of advocacy also include activism, publicity, lobbying, and policy analysis. So just to differentiate a couple of terminologies like advocacy versus activism. So in advocacy, what happens is most of the times you work within the system, because you point out problems, but you also provide solutions, and you are willing to work with the government or with the system to rectify these problems. Whereas in activism, many a times this is a part of advocacy which is very helpful to bring to attention topics. So you are outside the system, and being a civil society member or being an active health advocate, you can raise concern on a particular issue. Advocacy versus IEC. So in advocacy, there is a particular cause that you are trying to get support on from different members, whereas in IEC, it is more individual oriented, wherein you're trying to bring about a behavior change or a change in their values and beliefs of one individual or a group. So why advocacy? So if you just see the case of tobacco control, there are so many individuals, so many organizations working on this issue. But if these efforts are not in a orchestrated manner, you can have people reinventing the wheel and doing the same things, not knowing that it's already been done. Whereas if a coalition is so strong that there is a sharing of information and everybody is focused, it could lead to better outcomes. So just a few steps. Firstly, what is the issue? So if I talk in this context, suppose the issue is to set up a cessation clinic. So that is your goal. Now you need to develop messages. So in your case, suppose you want to advocate for a cessation clinic in your private hospital or in your government setup, you need to develop crisp messages that why is putting a cessation clinic necessary? What are the quit rates? What are the advantages on other health outcomes that you can achieve by helping people quit? Following this, you need to identify some key individuals who have been working in this area and build a support network. You may also require funds. So this involves in the planning of an advocacy cycle, and you need to consider the various sources that will be available. After this, once you chalk out the plan, you need to implement it, and you need to monitor continuously. So this is not a one-time action. You can keep looking back at your plan and revise it as and when you proceed. Some strategies may not be so effective, so you need to relook and kind of change it. Who are the important stakeholders for a health advocate? Firstly, it's the beneficiaries. So in our case, it could be the tobacco addicts, the decision makers. So here there are policy makers, there are people from your own health facility whom you need, whose support you need to set up the facility in the first place, your allies and partners, so your doctors, your counselors, all of these, and adversaries. So maybe there are some problems with funds or any other things. So you need to always have a tab of your allies as well as your adversaries. To just summarize the characteristics of a health advocate and what are the main things that the attributes that help in a successful advocate are: one is the passion. So be it tobacco control, if you're really passionate, like being a dentist, why I would be motivated is because I have seen so many cancers, and the age group coming down now. So that is one of the reasons, the passion for the cause. Next is the precision. Like I said, good advocacy is useful only if it is well informed. So you need to have precise data on what you're planning and how you plan to execute it. Promptitude. So sometimes the system does give you an opportunity. You need to be on the lookout and be very prompt in responding favorably. Perseverance. I put up a question to Dr. Murli saying that would you ever give up? But it shows, I mean, be it quitting, be it tobacco control, perseverance is the key. And a personality. You need to have a personality such that the person that you're communicating to understands the genuineness and is willing to take up your cause. So just to draw a couple of things from our work from tobacco control. So one very significant motivating factor for policy decisions, especially with high-level policy makers such as be it the health ministers, the chief ministers, there has been this group of patients called Voice of Tobacco Victims. And they are a set of people who have undergone various treatments, especially for cancer. So we have farmers, we have retired people with gallantry awards from the Indian Air Force, we have general young children coming in, and these people, usually you find them very difficult to motivate them to come out in the open and approach even the general public for that matter. But this Voice of Tobacco Victims provides them a platform wherein they all help each other, because many a times doctors may not have time to explain to them how to use their voice boxes and how to cope with the daily routines. So this group, Empowered Patient Group, in a way has been one of the key game changers in policy advocacy. Many a times we would have seen these gory pictures, but we would have never interacted with a cancer survivor. So these patients come and they meet children, they meet policymakers, and they try to spread awareness. And finally, in any advocacy, it is always good to go work hand in hand. As I said, coalitions, be it outside the government or with the government, is very helpful. So in case of tobacco control, I think our colleagues further will be talking more about this, that how governments and civil society organizations and individuals can come together to actually bring about a change. Thank you.
Great. Thank you, Dr. Pragati. Since the three presentations are all linked to tobacco control outside the clinic, I'm going to request Dr. Jagannath to make his presentation. And then we'll have and Mr. Prabhakar, and then we'll have a discussion around all these important areas about advocacy and control. As I mentioned, Dr. Jagannath is the consultant for the tobacco control program in Karnataka. Karnataka has been a very active state, with a lot of activities around tobacco control. So he's ideally positioned to really talk about it. And these might give you, those of the listeners from participants from other states, ways of kind of forming advocacy and coalitions in your own states and regions to actually take tobacco control forward.
So, good afternoon, one and all. I'm Dr. Jagannath, working as a state consultant for National Tobacco Control Program. So, today in my presentation, I'd like to have a discussion on how to set up tobacco cessation centers at district hospitals. So, I can say that the year 2015 has been remarkable and is a landmark for tobacco control program in our country, because the government of India has been working very hard to set up tobacco cessation centers at the district levels. So far as Dr. Murthy was discussing about setting TCCs, it was only mostly related to apex institutions and medical colleges and dental colleges. But since most of our people, most of the tobacco users in our country are from the grassroots level, so it's high time that we set up tobacco cessation centers at the district level as well. So this presentation, sorry. Yeah, thank you. So basically, we have these key strategies in setting up tobacco cessation centers at the district level. First will be the training of specialists and our general practitioners and general physicians. Our first training session was successfully fulfilled by Dr. Prabhat Chand at our health services offices. So most of the doctors who were program officers related to tobacco control, psychiatrists from various district hospitals were part of the training program. And next we are focusing on establishment of tobacco cessation centers. Dr. Murthy has already given the flowchart of how exactly to establish these cessation centers. So because of this, I'll not be focusing much on the establishment strategies. And then we'll be focusing on the IEC activities as well. So following to that will be the most crucial and USP of any tobacco cessation center at district level will be the referral and follow-up mechanism. So how exactly will our referral mechanism will function, and followed by that, what is the follow-up mechanism that we will be establishing at these centers. And another concept that we are trying to establish is to integrate this tobacco cessation services with other national health programs. And we are also planning to have a tobacco quick line, a centralized tobacco quick line at the state level, so that we will synergize the effect both with cessation centers at district level and at the state level as well. So when it comes to training of specialists, we mostly focus on the psychiatrist and followed by psychiatrists, preferably general physicians. We also train medical officers and dental officers. So the key persons at the grassroots level, at the primary healthcare level, will be our medical officers who can easily identify tobacco users and begin treatment, or they can refer these patients to the higher centers. And definitely, of course, the dental officers who are the persons working at district hospitals, community health centers, and also taluk hospitals. So they are the key persons who will be identifying the tobacco users initially in their OPD services. And then preferably we will have a treatment module that makes the job of the clinicians a lot more easier to identify cases, differentiate between smokers and smokeless type of users, and give them the treatment regimen based on their frequency of consumption. So these are the treatment modules that we are trying to establish. And apart from that, definitely case studies and a strong reporting mechanism. We are closely in touch with Enhance to develop a software for these cessation services. So how to establish a tobacco cessation center at a district hospital, especially in a government sector? So first we need to choose an ideal location to set up these centers. So we have preferred to set up these cessation centers at close proximity to NCD cells, the non-communicable diseases cells. So what happens usually in these NCD cells are the patients are counseled for various non-communicable diseases like diabetes, hypertension, cancer, and other NCDs. So ideally speaking, any tobacco cessation center in close proximity or adjacent to an NCD cell will draw more patients, more tobacco users for the services. And the procurement of equipment should be need-based, be it equipment or drugs. As Dr. Murli was focusing on having carbon monoxide monitors and spirometers. So some hospitals, district hospitals, do not have spirometers at all. So in such a case, they can do a need-based assessment of whether to have spirometers for their hospital. So it will be an additive feature for such cessation centers. And definitely when it comes to manpower, a psychologist or a counselor is the key person to counsel these tobacco users, and the social worker who will synergize at the community level to bring in tobacco users to these centers. And when it comes to hospitals, at the government sector, availability of drugs is very, very crucial. Given the fact that we need at least 500 to 800 gowns per person, and the cost will work out nearly up to 2,000 or 2,500 rupees. But most of our national programs do not have so much of budget, given the fact that we have a free drug policy. So we cannot charge even a single penny at the centers for provision of these drugs. So we need to intend in such a way that we will never go short of such NRT drugs. So coming to IEC activities, that is information, education, and communication. First and foremost, criteria is to give a catchy name for these tobacco cessation centers. They should not be generic. So, for example, adolescent health clinic is called as Sneha Clinic in our state. So, similarly, we can give a catchy name. For example, we have just had a discussion to give the name as Mukta. So Mukta is to get rid of any habit. So any such catchy name will be a welcome move for identification of these tobacco cessation centers. And a very concise and comprehensive patient card. A patient card should not be just similar to any OPD card. It should also carry information about all the ill effects of tobacco, what a person needs to do in case they have to quit tobacco, and what are all the benefits of quitting tobacco. They should also comprise of any self-assessment cards so that they come out with a self-assessment to say that where exactly they are standing, at maybe at the end of 1 week or 1 month or 3 months or 6 months. And similarly, to propagate the message that there is a tobacco cessation center at the district level, we need to have IEC materials such as posters and banners at all the health centers. And preferably, we need to promote this tobacco quitline number. For example, we have 104 services in Karnataka, which I'll be talking about in the coming slides. And when it comes to IEC at the district hospital, we can have focus group discussions with tobacco users and successful quitters. A group of 7 to 8 people who are currently tobacco users, among whom nearly 40 to 50% have already quit tobacco, so that this will have a cascading pattern of propagating the message of how exactly their experience was when they were tobacco users and how can they help others in inspiring them to also quit tobacco. So such focus group discussions on a weekly basis at hospital will be a very good IEC activity. And another concept that we need to introduce in IEC is to identify tobacco users right at the OPD level. So since we do not have any of our OPD sheets in our state that can capture this history of tobacco use, so we need to establish a newer mechanism to identify such tobacco users right at the OPD level. So these are the few IEC activities that we need to that we are doing as part of these tobacco cessation centers. So then coming to the referral and follow-up mechanism. So we are establishing monthly meetings with the hospital staff at the district level and also at the taluk level. So in these monthly meetings, we will motivate all the hospital staff, be it specialists, doctors, medical officers, staff nurses, or anybody else. We will see to it that all the patients who come to various blocks of the hospital will be referred to these cessation centers if at all they are tobacco users. And we also need to see to it that referral slips are available at all primary health centers, CHCs, taluk hospitals, and all the blocks of the district hospital. And a well-established follow-up mechanism is that we will have to bring these patients back to the clinic at the end of first week, then 1 month, then 3 months, 6 months, preferably at the end of 12 months as well. So this is the referral and follow-up mechanism we are establishing at all these tobacco cessation centers. Then another important issue is to integrate with other national health programs. For example, RNTCP, that is the Revised National Tuberculosis Control Program. So most of the people who suffer from TB may also be tobacco users. So we have to identify all these tuberculosis patients who are on DOTS therapy and refer them compulsorily, preferably compulsorily, to take these tobacco cessation services. And coming to maternal and child health. So since maternal smoking is rampant in our country, be it even smokeless tobacco use, and to prevent sudden infant death syndrome, parental smoking should also be avoided. So for that reason, any mother who registers for maternity services, they should also be captured for any tobacco use or any person in their family who is a smoker to avoid such infant death syndromes. And then we also need to integrate with NPCDCS, that is the National Program for Cardiovascular Diseases, Diabetes, Cancer, and Stroke. So this is the USP of our program. So without integrating tobacco control with NPCD's program, probably we will not be able to gain the desired results. So these are the three programs that needs to be integrated right at the district level. And coming to the centralized tobacco quit line. So this is a feather that should be added to tobacco cessation centers. We can reach out to maximum number of people within a short span of time. So since we have 104 services called as Arogyavani in Karnataka, we can very well make use of these tobacco quit line centers, have 2 or 3 counselors in these centers and give them counseling. One good concept about this tobacco quit line is that doctors are available on call and they also give prescriptions, over the counter drug prescriptions through SMS. So they are free to show these messages to the pharmacist and take these drugs. For example, since nicotine gums up to 2 mg are over the counter, so these can be prescribed through these quit lines by the trained doctors. And another add-on feature can be having a Skype call with IT professionals, those who are well versed in computers, and also a callback facility, preferably once in a month or so. Definitely will give a good motivating factor for these tobacco users as well. So these are the few concepts that we are establishing in these tobacco cessation centers at district level.
Thank you very much, Dr. Jagannath. I think it was very useful to hear in terms of now moving away from clinics in hospital-based clinics to now to the entire district and how to cover it in the district. I'm going to really challenge Mr. Prabhakar in the next 5 minutes to share with all of you the exciting work that Karnataka is doing. I'm saying 5 minutes because then it will allow us at least another chance to take up a few questions after that. But I'm sure everyone wants to listen to the exciting work Karnataka has been doing so far. Somebody asked for the backgrounds of Dr. Jagannath and Mr. Prabhakar. Dr. Jagannath is the consultant for the state tobacco control program in Karnataka. Mr. Prabhakar is working for the union in terms of tobacco control in Karnataka.
I think the question is from Deputy Director of the Oral Health from Maharashtra government. So you can connect to him and
Yeah. We're looking to develop synergies in different states. So, if people are planning to start these in other states, they could look up to Karnataka. Mr. Prabhakar.
Thank you, and Dr. Prabhakar. Next 10 minutes, I'm going to discuss about what are the tobacco control updates in Karnataka. So, in state anti-tobacco cell, we are running a project called Effective Implementation of Tobacco Control by Capacity Building, Enforcement and Monitoring, with the support from the union. It's funded by Bloomberg Initiative. The key component of this project is setting up and strengthening the systems, capacity building, enforcement, monitoring, and documentation of best practices. In Karnataka, we are working in all the 30 districts of Karnataka, and I have marked some of the districts in yellow color, that is 10 for focused districts, that is Bangalore Urban, Bangalore Rural, Ramnagara, Mandya, Mysore, Assam, Dharwad, Belgaum, Yadgiri, and Gulbarga, and we are giving focused activities to these 10 districts. So totally we have 7 staff, including me, that is project coordinator, 1 finance admin, and project assistant, and 4 divisional coordinators throughout all the 30 districts of Karnataka. The basic work what we did in the initial of the program, we did the baseline survey to understand the quantum of the problem and what are the current situation of Karnataka in terms of tobacco. So we did the mapping of all the key departments under the Karnataka government, that is health, home, education, panchayat, transport and tourism. And we also did the one-to-one interaction with the key stakeholders of the government officials. And we also, now the current state is all districts have district anti-tobacco cell, consists of DC, ADC and other representation of other departments. And we have state anti-tobacco cell at the state level. And in the mapping, we have developed the template and identified the key government departments which we have to interact for the tobacco control program, and identify more than 50 key stakeholders in each district, and identify more than 5,000 public places from all the districts in Karnataka, and we collected the address, email IDs, contact numbers of all government departments. This is very important information to continue our program. So in one-to-one interaction, we met more than 700 project stakeholders from government and civil societies across the Karnataka, and visited key government departments and established rapport with the officials by sensitizing about the project, and visited government and new websites for collecting mapping data. Under our project, we have completed 27 workshops on district level sensitization. So the key objective of this workshop is to sensitize the government officials about the tobacco control laws and the ill effects of tobacco control, and the role of the government officers in implementing the tobacco control law, that is COTPA, the Cigarette and Other Tobacco Products Act 2003. And in the second level, we also did the enforcement officers training. We have completed 27 workshops in 27 districts. So the key objective of this workshop is to train the enforcement officer to how to implement the tobacco control laws. Because in the initial need assessment, we thought that the government officials are not aware about the COTPA. Number one. Number two, they were unaware about how to implement the tobacco control laws, and what are the sections, and what are the mechanisms they want to implement this law. And in the Karnataka, so far we have completed 56 DATC quarterly review meetings. DATC means District Anti-Tobacco Cells. It is a district level setup. So in this, we have completed 56 meetings. In these meetings, we review how the tobacco control is implementing at the district level, and what are the gaps in the tobacco control program at the district level. And we also did the sensitization program for the hotel and restaurant owners, traders, tobacco vendors, and lawyers. And we also did the training for taluk level officers, and we did the state level sensitization workshop. And for the central government officers also, we did one workshop. So the many circulars are issued by state and district level authority or tobacco control program. And so I'll give. So now we have. I'll give some of the data about the enforcement activities. Total 9,059 Section 4 cases have been booked so far, and around 1,55,310 fine amount has been collected under Section 4. Under Section 6,
Mr. Prabhakar, what is Section 4?
Yeah, Section 4 is prohibition of smoking in public place. In this, we have booked 959 cases. And Section 6, it is prohibition of tobacco selling to the minors and by the minors. That is 6A and 6B. Under this section, we have booked 249 cases, and the fine amount is around 38,720. Under Section 5, that is prohibition of advertisement of tobacco products. That is 160. These are the cases booked by DATC team, that is District Anti-Tobacco Cell team. But we have a big number of data by police department. And in Karnataka, police is doing a good job in the enforcement of COTPA, the tobacco control law. This is one of the photo. Under this project, Bangalore Rural declared as smoke-free on 3rd December 2014. The Health Minister of Karnataka has given the declaration certificate to the Bangalore Rural DC and other health officials. Under IEC activities, we printed 3,000 COTPA law manual books and distributed to all the district level and state level officers. And we have printed 7,500 Section 4 signages. I'll show you in the next slide. And 4,568 signages and 725 signatures for the government officials. We have involved media also in this program to give a visibility to the program, also to create the awareness in the public. And this is one of the best practice of our program. We implement we did the training through theoretical and field experiences. And for more information, you can go through our website, ftc.kl.in and www.stoptobacco.in.
Thank you very much, Mr. Prabhakar. That was very informative. So, as you're aware, there's a lot of activities happening in Karnataka in terms of implementing tobacco control. So, tobacco control is not only about tobacco cessation. It's about providing information about the harms. It's about taxation, It's about monitoring tobacco, control mechanisms. It's a whole lot of things, and advocacy and other measures of control also become very important if you want to effectively control tobacco. Prabhat, are there any final questions we need to take up before we conclude? I know there have been a lot of questions.
Yeah, I think. And the DO of, I told you, DO of Pune wanted some question about basically about cards and what you spoke about the card, follow up. Probably what I'll do, I'll connect both of you.
Okay.
And somebody wanted email ID. Yeah. So what I'll do, I will connect the public health personnel from state of Karnataka to all of three of you to the state of Maharashtra and anybody you need. So you can basically liaise among each other and probably sometime next future forum could have presentation in both the things. Correct. And yeah, I think any questions? Last moment question. I know probably the hall is full, but nothing is coming up.
Any questions from our postgraduates?
Okay, so I think I have to do the last part. Give me a minute time.
Okay, in the meantime, let me just thank all the panelists. Dr. Sujata, I'm sure you're still listening. Thank you all for being here and really giving it a very diverse perspective in how different people, different players need to network and come together in keeping with the spirit of our program. Dr. Prabhat, over to you.
Yeah. It's not okay. Now I think it's my ritual to finish this session because a lot of things are involved in the whole thing. Now I just want to tell, probably we've finished almost a year of running these weekly sessions with few breaks in between, which is a huge task by itself. I want to show it, how it started. Few couple of minutes I will tell. We did a pilot in March, April 14th in a small room in a department, and first time we started the alcohol module and learned a lot of experience. Second time we did opioid, and that is the time when we integrated with a learning module, which I just speaking to all of you. Please access this module and get the questions and answers. Did third module in September 2014. Then obviously 2014 November we started recording the modules, and as you know, current session is recorded now, and I think there are a lot of people who are participating now. Few of them are actual presenter. I can see Ashish, Saurabh, who has been presented cases in this forum in this, and they some printed out of session and some printed here. Thanks to all of you for sharing responsibility. So since November 2014 we started basically developing a learning repository where you have recorded videos and presentations. This is the current module. This is the last part of the module. Now we thought of sharing with our outreach. We have actually crossing a huge number. Sometimes I wonder, our scope is 100 spokes, but there are 600 registration. Luckily, not all are logging in same time. If they log in sometime, I can make sure some people cannot access it because this capacity of this is 100 spokes. So by we can reach. I was looking at yesterday. We are reaching almost south and north. You can see, and northeast. I didn't point out some of the areas where like Rufa, as could see, she logged in. She logs in from UAE. And some people from Sweden, US. Of the time difference, it's very heartening to see there is a keenness in learning. And this is a worldwide map. And the bottom in the sea, who is 3% definitely. It is Google Map. It's picked up the Excel sheet. So no idea. So thanks to all our research person for current session. Priyanka, who is take up MD in CMC Vellore, Pawan, who is a resident, Charisma, and today's basically research person, Dr. Murli and Pragati, who is presenting Visa. So thanks all of you coming here. Swati Prabhakar is not there. Last minute entry. So thanks to all. Thanks to Madam for chairing more difficult session. Thanks to all knowledge partners from various parts of the country, small town, big institute, from various fields to take out time for this learning process. I can imagine 2 hours sitting one place and assessing whole thing for 50 participants. Today we actually We have almost 47 participants. Thanks to YouTube for agreeing to provide space without any financial cost and during 11 hours of time, we can upload to that. Mr. Director and Government of India, all the residents for the time, an entire team who has actually donated the time for the whole program. I think, yeah, this is the same thing. Now, thought of announcing two things. We are actually taking a break now. We will come back in July. In July also, we are starting another echo. We call R2R, Road to Recovery, basically on chronic mental illnesses by psychiatric rehabilitation team. It will be monthly session on Friday. Apart from the Tuesday sessions, I will communicate to you. Third is the most important request. We will send you post-test and feedback. Please do it. You will receive the link shortly. It's online. And request all of you to present cases in the next slide and next time in July. And obviously, do visit our website. It's get regularly updated now. And if there's a forum to comment, you can definitely give suggestions. Okay.
Prabhat, can I just also add that I think please also give us a feedback on other sessions that you would like to cover. I mean, I think it's very important coming from all of you what you would like covered maybe in the next few sessions. So please feel free to suggest topics so that it will infuse us. Prabhat's vote of thanks sounded like it was the ending. It's only the ending of 1 year. It's going to go on much stronger, much newer, much more innovative, and that will depend on your comments.
I think thanks to all of you for your time. We'll meet again in July. Thanks to a lot of thanks from different people. Okay, I'll close this thing now. Thank you all.
Thank you.
No, just go ahead, ma'am.
I just wanted to say that you get to